Ladies and gentlemen, I'd like to try and keep to time if possible. My name is Kathy Wilkinson, and I'm a clinical coordinator for NCPOD. And I've been a clinical coordinator for 10 years, and I'm extremely pleased to be introducing such a lovely session on communication, which we continue to do usually quite badly, sometimes spectacularly well. We don't use language very effectively sometimes. We don't listen to each other or to patients. And NCPOD has revealed this in many of its reports. So for the first 10 minutes, before I introduce a panel of fantastic speakers, I'm just going to give you my own thoughts and a little bit of musing on communication to begin with. So I was fortunate to go to Barcelona in the summer, and there's Picasso on the left and one of his early pictures, Science and Charity, a picture possibly telling 1,000 words. I think he was only about 14 or so when he painted some of these pictures. Amazingly good and amazingly communicative. So the art of communication, I was just playing around a little bit with the title of this session and thought it would be quite useful to just think about that. What about the science of communication? David Attenborough, 82 years worth of not necessarily televised but broadcast Royal Institution Christmas lectures. Let's hope that the NCPOD Christmas lecture becomes an institution as well. But here he is, showing and not telling. So this is the science of communication. And there's a lot of similarity, I guess, in that people are showing and not necessarily telling, and going back to the idea of people listening and as watching, and that's what NCPOD perhaps does very well. It reveals things by showing them and not necessarily wagging a finger at people and telling them what to do. It's fairly obvious from the data, and no data with no stories without data. And I'll tell a few stories which Ian has earlier, which I think bring the NCPOD reports to life. So a lot of reports, 25 or so, where communication has been highlighted as a problem in all sorts of guises. And I won't speak very much on individual reports, but I think it is just important to show you the front covers. And we've said that the artwork has changed a lot over the years, and that's definitely not thanks to me, but thanks to many others, and Marissa and a team of people, including the designer and ourselves, going, yes, that looks good and that means something, and having brainstorming sessions in the office with the most amazing team of people that I've ever worked with, who think about what the title should be so that we can communicate these things very clearly. So here are some of the common communication themes that run through like a really strong thread through the reports. And most of the time, these issues aren't dealt with terribly well. Sometimes, though, there are really good examples that are found when we're looking through case notes of trusts or individuals who communicate really, really well. And I think it was the president of the College of Surgeons who spoke earlier in the session was talking about documentation. And I think documentation has got better. And if it isn't written down, he's quite right. It's not obvious that anything, what has occurred and has anything meaningful happened. I think we have got better over the last 20 to 30 years in documenting. The highlighted areas I'm just going to speak about in a little bit more detail, in that I'm going to bring a report forward just to tell you some data and then a story. And Ian has already done that very elegantly, but I've got a couple more stories from different reports. So a little bit about us working together as a team. and we're not always good at it. We sometimes don't have a multidisciplinary team, or at least we don't have a formal multidisciplinary team, but we're not sometimes very good at working alongside our colleagues to make sure that we have a coherent plan that's well communicated. And these are some reports that highlight this, and this is one report in particular which hasn't been mentioned to date, but is one of a suite of reports looking specifically at care for children, young people and young adults up to the age of 25 years, which is relatively new work for NCPOD, and this was a particularly complex area to start with, in that neurodisability care was one that had been shown by the RCPCH and others to be very poorly done, and so this was chosen as a topic for a report. So one of the themes from the outset, the objectives, was to look at transition of care, because we know that transition from paediatric to adult care is appalling. We know that already, and so could we highlight it in this area? And this graphic at the bottom is fairly simple. It shows how well the reviewers who looked at case notes felt the care had been delivered in terms of multidisciplinary care for the different age groups. So paediatric, inpatients and outpatient care versus adult, outpatient, inpatient and outpatient care. And as you can see, there was room for improvement, particularly in the adult care. There was room for improvement right across the board, but particularly at the transition to adult care. And so this became a principal recommendation that there needed to be improved multidisciplinary care. And there is a separate recommendation, which I'm not putting up here, on the need for much better systems for improved transition into adult care. But the simple fact is that very often there isn't a lead for care on the other side of the gap. And the case study reveals that. So a young person with moderately severe cerebral palsy has got to the stage of needing a wheelchair and needs to go to university 50 miles away. A huge landmark in that young person's life that they've made it to get to university away from home. But actually the last letter that could be found in the notes was a consultant paediatrician who could not identify a lead for neurodisability care in the adult zone. And the reviewers that looked at those case notes agreed that there was a real need for better involvement, and that very often, it's not mentioned here, but very often actually the patient's GP hadn't been particularly well involved in care up to that point, but then was required to take over leadership. And we can see why this young person fell down the gap. Organisationally, we need to communicate in networks, and we know that isn't a new recommendation. We talked already about trauma networks and the efficiency of that and the importance of that. And here are some reports saying whether networks existed and how they worked. This is also quite an old report, and slightly a Cinderella, I suspect, up till recently. This was before NCPOD covered Scotland and before we had the last reorganisation of the health service, so we were still dealing with strategic health authorities, which are on the bottom. But we asked, from an organisational point of view, whether there was any participation in any sort of network of care, formally or informally, around the surgery, the general surgery for children. This was the Are We There Yet report that was published in 2011. The third report on the care of children in the perioperative period, which indicates to me that there is a problem. This was a case study from the report about a child who has a short history of abdominal pain, presents to their local hospital. The surgeons decide they need anaesthetic review and resuscitation. After that had occurred, they also felt that the jam just wasn't going to be the right jam. and the child needed to move. It took 10 hours to get them moved to the specialist centre. They had their gangrenous appendix removed, went into multi-organ failure and died. You won't see many of these. This was a report looking at 2 years worth of cases. Thankfully, that is the case. But this is a spectacularly bad result for a child with normal physiology who had an eminently treatable condition. NHS England are currently working very hard to try and establish, if they're not there, these networks of care. And we're another 7 years down the line. So there would be no talk about communication at the present time, I think, without saying something to Kate Granger or saying something of her, because unfortunately she's deceased. But her campaign to say, very basically, to speak to our patients, to say hello and tell them our name, it's so fundamental that we absolutely had to put it in here. It's simple, it costs no money and very little time. Now I know Trish is going to speak very soon about spoken communication, and I'm a big fan of that too, trying to get spoken communication right. But actually we also have systems to help us get communication right. And I think Ian had mentioned this in his first talk about the enduring power of the NCPOD classification for intervention. It helps us communicate with each other, but it also, as far as I'm concerned, helps me when I'm doing a preoperative visit to say to the patient, this is what I feel in terms of the urgency of your procedure, and I know how to define it. So it has become common language in my neck of the woods. It's simple, it costs no money, and takes hardly any time. Thank you very much.